Hey there, micro friends. Welcome to another episode of Let's Talk Micro. As always, I am so happy that you're here with me. And if this is the first time you're listening to Let's Talk Micro, well, thank you for choosing it as one of your podcasts. Okay, so this episode is it's longer than normal. It's over an hour, and I apologize for that, but this is great content, and then kind of splitting it into didn't make too much sense. So it is longer. So I'll be brief. In this episode, we're diving into antimicrobial resistance from a true One Health perspective. And in this episode, I'm joined by Dr. Kelli Maddock and Dr. Stephen Cole. And in it, we are talking about the challenges of antimicrobial susceptibility testing in veterinary medicine, the role of genotypic and phenotypic testing, what makes veterinary samples so unique, and why every animal result matters for public health. So let's go ahead and listen to it. Hey there, micro friends. As you know, I recently attended an AMR antimicrobial resistance summit in Detroit, and I told you a little bit about that. And stay tuned; we're gonna be doing more content about this. But one of the things that I saw in there was, some of the guests. There were some from the veterinary microbiology, and as you know, this is something that I have explored with you before in the podcast. And I thought it would be a good opportunity to do an episode about this, talk about AMR, and talk about a One Health perspective. And as always, in this format, it is always great chatting with new people, meeting new people, and also chatting with friends of the podcast. So with me, I have a repeat guest and someone that is the first time guest here. So joining me, I have Dr. Kelli Maddock and Dr. Stephen Cole. Everyone, welcome to Let's Talk Macro.
Thanks so much. I'm so excited to be here.
Yeah, thank you.
Oh, what a pleasure. Definitely, Stephen, welcome to your first time as a guest. And as always, Kelly's been around a few times and it's always great chatting with her. So it's gonna be a good episode. I feel it. So I think that, and you done this before, Kelly, but maybe we can both of you start with sharing a little bit of about your professional background and how you became involved in AMR and One Health research.
Sure. I am a veterinarian by training. I'm a typical veterinarian in that I grew up always wanting to be a veterinarian. So I was like one of those, 5-year-olds walking around saying I was going to be a veterinarian. And then when I applied to vet school after college, I didn't get into vet school the first time I applied. So I actually was looking for a way to bolster my application to veterinary school, and I had enjoyed microbiology in undergraduate. So I reached out to a fish microbiologist, and I started doing research, and I did my master's degree in a fish microbiology lab at the College of William and Mary. And then that opened up the doors, and I got into a whole bunch of vet schools. And then I thought I would just keep going on and being a veterinarian, a practicing clinical veterinarian. And then when I got to vet school, I found I really missed my time in the lab and really missed microbiology. And so I took some opportunities to do summer research at the vet school. I'm at the University of Pennsylvania. I went to the University of Pennsylvania for vet school, and now I'm a faculty member there. And I spent a summer in a research microbiology lab, and that was okay. I didn't hate it, but I didn't love it. And then I spent my second summer in our diagnostic microbiology lab and absolutely fell in love with the marriage of, the clinical side and sort of the laboratory side as well too. And so from the moment I realized there was something called a veterinary clinical microbiologist, I'm pretty sure I knew that's what I wanted to be. So I then went on to do a fellowship here at Penn Vet in clinical microbiology, and then became a board certified veterinary microbiologist by the American College of Veterinary Microbiologists back in 2018. I joined the faculty at Penn Vet in 2020. And that brings us to today, basically. And so I ended up, AMR is a problem we see every day in the lab. And so, every day I talk about my research wanting to guide problems that I see in the lab. And so, it's really these challenging cases that we see in the veterinary hospital here at the University of Pennsylvania and across sort of the Commonwealth and the country that my laboratory serves that have really driven some of the work that we've done.
Yeah, and for me, I'm guessing there are people that have listened before, maybe familiar with that background, but I started out as a medical laboratory scientist working in a human laboratory and got burnt out and eventually got poached, I guess, to veterinary medicine by a veterinary microbiologist who had similar training to Stephen. And no matter how many times I hang out with Stephen, I swear I learned something new about his background, and I absolutely love it. Um, so Okay. So, got poached into veterinary medicine and began working at the veterinary diagnostic lab at North Dakota State University. And then through that activity, I started with the Clinical and Laboratory Standards Institute, or CLSI, for the veterinary microbiology group, and met great people like Stephen. And he was very kind to me, even in my first time at CLSI, and had a good chat and gave me confidence in joining, and just dug more and more into everything. And it was just really interesting. And so that passion has just continued to grow over time. And of course, seeing really bad infections and the impact of AMR drives that passion.
Okay, well, thank you for sharing your stories, and and something so true, and I know we definitely talked about this, Kelly, before, and but it's one of the sad things about this field, and it's such a great work and important work, but there's so much work. That's one thing that it's a constant there, and sometimes those days in the lab, they seem so long, and it just the pile of plates, and while it's exciting learning and rewarding what you're doing, yeah, it just that life work balance, it gets us skewed so many times, and unfortunately we see good people that they end up taking another turn or going someplace else or doing something else, because we also have to value our life, our family time, and things like that. So it's very important. So hopefully, as we go along, maybe some of those things, we can continue overcoming them and maybe correcting them, because we don't want to lose, good people and things like that. So we want a better balance, and it's hard attracting microbiologists to our field sometimes, because they're like, well, it's never 8 hours. It's just I'm always staying late, so I don't want to do that. So for the audience, there's going to be a collaboration that Stephen and Kelly worked on that I'm going to put the link on the show notes so you can review it on your own pace, read it in more details, and we're going to be referencing this on the episode quite a bit. And maybe if this is the first time you're tuning in, or if you have already listened before, veterinary microbiology is very fascinating. And we did some episodes with Kelly where we kind of shone a light of what they do. So I invite you to check those out. So your collaboration, which is titled Current State and Future Directions for Veterinary AMR Research, what inspired this collaboration?
Stephen and I were actually tasked with CLSI to do this. And by tasked, I mean voluntold by Dr. Dubra Diaz Campos, that we would be co-chairs of a molecular and microbial susceptibility testing work group. And this actually arose because we're still working on an appendix for our Beta 1S, which would be analogous to the CLSI M100 that you'd use commonly in a hospital. But just coming up with guidance for laboratories trying to interpret AST and incorporate genotypic work into their clinical practice. And part of that, I think Stephen can probably speak on this a little bit more too, is we actually what drove it a bit was there are companies that actually offer whole genome sequencing of samples and suggest treatment based on this sequencing. And I bet Stephen could comment on that just a little bit more.
Yeah, I mean, I think a big take home of that whole project that we worked on, Kelly, was that um, there's some incredible work happening out there in antimicrobial resistance in the veterinary field. In my opinion, it was all very sort of oriented towards human health, as like a downstream effect of everything that's happening in veterinary medicine or in agriculture. And while certainly that's one perspective, I think one of our goals of writing this was that certainly one of the best ways for us to practice better antimicrobial stewardship and diagnostic stewardship is actually to have the research on the clinical side of veterinary microbiology and AMR and antimicrobial susceptibility testing to actually like sort of guide how we can do it all better. And so I think really for me, ultimately, the reason I said yes to that voluntelling was that, it's about like creating a better clinical framework for us to work in. Because, you know, we can look at the downstream effects, but if we don't look at the sources and the challenges that we have up front, then it just becomes a blame game, right? And so I think one of the big arguments for us doing this article was to really like try and point out it's challenging to do it well when we have so many holes and gaps.
And just to lay that framework for how it could potentially be used in veterinary medicine for sure. We do need more diagnostic tools, and definitely these rapid genotypic things would be great. Not saying that they aren't, they just have to be used properly, and we need evidence for those.
Okay, and and for the audience, right? We have like this nice blend of everyone from students, professionals, all sorts of roles in the microbiology and infectious diseases community. So maybe we can start with a little bit of some basics, and your paper, it frames AMR as a One Health challenge. So maybe we can begin talking a little bit about that and what does One Health look like in practice? When we think about human, animal, environmental sectors, how are they connected when it comes to resistance?
Yeah, I mean, I think the more research that comes out about this, the more connected everything really is, right? So we actually just started a study in my lab with one of my residents where they're walking around looking for dog poop at dog parks that people aren't picking up, and we're checking it for big bad bugs. And, we were just having the discussion this morning of like, we're going to find these bugs. And yeah, people aren't picking it up. And that's a problem. But like, is storing it in a landfill just as bad, right? And when it comes to the environment. So, I think at the core actually of One Health, right, is sort of, yes, it's about animal health and human health, but like really good One Health has to have that environmental perspective too. And so, for me, ultimately, what One Health in practice looks like in the microbiology lab is being able to really sort of um, offer testing that can certainly involve both the animal and the environments that they're in. But also, I think another big part of the One Health is understanding, hey, what and flagging for veterinarians, what are the risks to people that are associated with these big bad bugs too, right? And so I think that at its core, right, it's about communication and interactions and being able to really sort of tie all the implications that a diagnostic result has for not only the animal in front of us, but also for environment, also for the people that are interacting with that animal, and ultimately maybe even the ultimate public health risks associated with that too. And so, when it comes to One Health, I think it is something that we just by nature preach. I will also say the other big thing about One Health is recognizing when you can't just take what we know in people and apply it to animals, right? Or apply it to the environment. Just because one test method or one breakpoint works in one species is probably not going to work in another species. And so understanding that there are things that connect us all, but there are things that fundamentally make these things different too, is really important when it comes to practicing good One Health, because it's easy to paint with a really broad brush, but to know when you have to dive in on the specifics is really important.
Yeah, and now you mention, and we'll definitely talk a little bit more about breakpoints as we go along the episode. But that's one thing you brought to mind, something that it was actually you said it in the summit, right? About the breakpoints, and we think about your CLSI 100, which is probably what most of the people in the audience understand that I'm talking about, and they know about the challenges with breakpoints. But it's a good point thinking about because it works in one species, right? Not working on another. And as you were talking, something came to mind, and I did an episode, and maybe Kelly, or Stephen, you as well about Grace Burke from Alaska, that she did some studies, with moose and bear scat, and they sampled them and over a year and stuff, and they discover like ESBLs, KPC, and but I do love the understanding that you bring to the audience and me as well about some things that sometimes we didn't know, like mentioning we talk about pastorella, and sometimes people, right, with that close relationship and becoming colonized. That's something that maybe us in the clinical microsector might not be aware of. So yeah. So now speaking of veterinary laboratories, and as I mentioned earlier, we have brought some light to this here to the Let's Talk Micro audience, and but maybe there's still a lot of there's unawareness, and so we want to learn more. We want to know more about what veterinary laboratories do. So what is the role of vet labs in AMR detection and surveillance?
I think they're very similar to what we would be seeing on the human side. Of course, the big difference being that we're getting lots of different species, and hopefully that our pets are probably licking themselves more than people are licking themselves. So, I mean, you're getting a lot of different kinds of contamination and things that you've got to muddy through that you don't really appreciate on human med. Um, those would be the big things, but then actually recognizing it in the lab and being able to communicate that significance to the veterinarian in cases of more critical things, then also hopefully you're being able to communicate it to public health authorities and just figure out how to respond. I think Stephen has some really good examples of where his laboratory has really helped connect some interesting stories. So I'll let him touch on that.
Yeah. So we serve. I would say we also serve a very. I want to highlight that diverse clientele that we really do serve in veterinary microbiology labs. So we can take the University of Pennsylvania, for example, as we actually have 2 clinical diagnostic microbiology labs here at the university, and I only direct one of them. So my lab handles companion animals. We do all the pets at the small animal hospital here. We also do lab animals, so research animals that are sick with infections. So for the entire university, come through our laboratory. And then we also serve other sort of populations. So we also do the Philadelphia Zoo, for example. And so we have a pretty wide range just for my little, lab here. But then out at our other campus, they're serving uh, all of the agricultural um, stakeholders across the Commonwealth of Pennsylvania. So we're doing cattle, swine, poultry. And then they're also doing, food safety testing, right? So they also do egg quality and promotion program out there, uh, you know, and so, and this is just the diagnostic bacteriology lab. So I think it's important to recognize that our role in AMR surveillance is broad and vast in veterinary microbiology labs because we are pulling from all these different sectors that tend to be somewhat siloed too, right? I think in on the human side, a lot of it's, either inpatient care or outpatient care, right? And those are sort of like the two, and then long-term care facilities and things like that. So obviously there's a diverse population there, but um, we kind of have to keep an eye on a lot in the veterinary world. Um, and then Kelli sort of mentioned some of the work that we've done in my lab that we've identified some unique um, concerns when it comes to antimicrobial resistance and the surveillance roles that we play. So our lab was the first to describe an outbreak of carbapenemase producing organisms in companion animals in the United States. And actually, that came out of a surveillance program. So our lab is one of the labs as part of the Veterinary Laboratory Investigation and Response Network that's funded by the FDA. It's this really cool and collaborative group of veterinary labs from across the country that all contribute to several different types of projects. But one of those projects is an antimicrobial resistance surveillance project. And so basically at the beginning of every month, you collect, 5 staffs, 5 E. coli, 5 Klebsiella, whatever sort of our target organisms are that month. And very early on in the program, we had seen this pattern of these strange E. coli's that were resistant to imipenem was what was on our panel. And we were like, oh, that's weird. That's not good. Right. But we didn't really have the tools that are um, uh, readily available to us. And it was our collaboration with the FDA's VetLearn that we were actually able to submit these isolates through that. And we actually identified Nudeli metallo-beta-lactamases in those isolates. And so it was really the first report of an outbreak in a veterinary facility. And it was with these strange carbapenemases, right? Like we would have expected to find KPCs, the most common in people, and our pets too, but we actually found these NDMs. And since then, that's grown into a whole research program for me. So I direct another lab, which is the carbapenem resistance enterobacterales Animal and Testing Epidemiology Laboratory, or CREATE Laboratory. And that is a reference lab for veterinary labs and veterinary facilities that are finding carbapenem-resistant organisms. And with that, we've found hundreds of isolates now that are different carbapenemase producers. And what's been really fascinating is about 95% of those isolates are NDMs. We very rarely find KPCs. We very rarely find oxofoliates. And I think this is quintessential One Health question because, just a few weeks ago, the CDC put out this report of this massive expansion of NDMs in people. And, a lot of the conversation about NDMs has been that they're more and more community associated as well, too. And so, we have pets where we're seeing potentially community associated and hospital associated NDMs, and then people as well, too. And so what we're seeing is a rise in this really concerning genotype and the associated phenotype rising in these two populations over the exact same time period. And so the question is like, what are the similar sources or what are the exchange of these organisms that's happening between these two populations? And so we were then funded by the CDC with a partnership with the Minnesota Department of Health, where we did sequencing and following up using regional public health departments to identify potential transmission pathways. And we found a really fascinating case of this that was actually just published in the Clinical Infectious Diseases Journal, where we actually were able to integrate whole genome surveillance data from the state of Massachusetts with our surveillance data from outbreak investigation that we did at a veterinary hospital in Massachusetts as well. And actually what happened is they had this group of 3 humans that had NDM infections that had no association with healthcare. And so we did our sequencing and we found actually that all of the isolates cluster within 1 to 0 single nucleotide polymorphisms across the entire genome. And when we put the sequencing together with that human surveillance data, we were able to actually unravel how those 3 people that were previously unconnected were connected. And that was actually by asking them, what do they have pets, and if their pets had healthcare exposure. And it turns out that all 3 people had had their pets hospitalized at the same veterinary hospital where we had been investigating that outbreak before. And so what we've been able actually to do is point to a transmission pathway of these really, high risk organisms that led to infections in people that we think was because of spread at a veterinary facility. And so uh, this just speaks to how complicated those One Health pathways are, but also the critical work that including animals and animal environmental samples into that data is really important if we're going to unravel these really complicated pathways, because without it, we couldn't figure it out.
Wow, such a great example. Oh, thank you for sharing that with us. And one thing you mentioned, Kelly, was that you'll talk about challenges and limitations when it comes to testing, right? And also in the collaboration, you talk about a balance between phenotypic AST and genotypic AMR testing. And so in veterinary diagnostics, what are some of the biggest advantages and limitations, in vet diagnostics, and maybe how close are we to seeing genotypic testing routinely used in animal labs?
Yeah, I think capabilities vary quite a bit depending on the facility. I think Stephen has really great tools, so he can use, I believe you use some Cepheid products for some rapid detection of critical antimicrobial resistance mechanisms. We don't have those resources in our little rural North Dakota facility at this point, but we do really good microbiology and try to detect those critical mechanisms. But the balance is using it wisely. In the situation where there are potentially tests being offered for whole genome sequencing with phenotypic AST results interpreted from it, it's a lot more questionable. Um, these aren't things that we're using in human medicine, but there are situations with Stephen's cases are the perfect example of that. Genotypic really adds some richness to those investigations and the epidemiology. So it's using it wisely and also having the right resources for it. I really think there needs to be an investment in veterinary diagnostics and genotypic tools that we can routinely use and that are affordable. Probably more for the bedside or point of care, kennel side, probably not bedside. So some of those tools would be really helpful.
And this is something, I'll take out, if I need to. But just, Stephen, just out of curiosity, so for that, those NDMs, was it just like NDM one, or no? I'm just curious because you hear about
Yeah, yeah.
presentations like NDM 5 that has like that variation,
These
right?
these were NDM5s. Yep, these are NDM5s. So the major ones that we've seen in animals are NDM5s and NDM7s. Yeah. So it's been those are really the big ones. Yeah, I think we've seen only one or two NDM ones. Yeah.
Okay, so you share your work. So when we talk about genotypic methods, and sometimes when it comes to testing, right? One thing is use the test, use them responsibly. How can genotypic methods, be used responsibly without, making room for overinterpretation or misapplying results in a clinical context?
I think it's just really practical and sensible use of that. We don't want to be testing samples that could be grossly contaminated and making wild assumptions. Oh, wow, we saw a. I always think of bovine respiratory, and just to add to that diversity, we see a lot of bovine samples, and there's I think a lot of idea for doing. You do a respiratory swab and you can detect, say, a tetracycline resistance gene, and then you just assume that these isolates are tetracycline resistant when in fact we know there are all sorts of contaminating commensals, and this is where the environment comes in. You have big nostrils in a cow, so you're getting all of these different things in there. So do you go based on that, or can you actually truly associate that tetracycline resistance to one of those fun Pasteurelliaceae causing disease? So like your Mannheimia, Hemolytica, Pasteurella multocida, Bibbersteinia trialosi, or Histophilus somni. Those are our big bovine respiratory disease bugs. So there's thoughts of using it that way, but it's not quite as clean, obviously, of a use. Clinically, probably similarly to in human medicine, where we're looking for methicillin resistant staph pseudo, or in the case of Stephen's projects, the carbapenem resistance um, genes. Those would probably be the most practical uses, but it's thinking about what are we actually getting from the data and how can we use it to guide our patient care and make it better? Or is it an epidemiological response or an infection prevention and control response? There needs to be something we can do with the result based on genotypic testing.
Yeah, just to jump in there on that, I think the other part is it has to be done in the context of the patient every single time, right? And so I think that this is really like I think one of the best things that lab can do is explain our limitations to our clients as well too, right? And that ultimately they're the ones with the patients in front of them. And so that ultimately that the data that comes out of our lab is only within the context of the patient, right? So if they've gotten better on that antibiotic, no matter what gene you find, or no matter what our AST says, right? You got to treat a patient, not a piece of paper, right? And then it also needs to be done in the context of a microbiologist and a trained veterinary microbiologist who has the context too. And so I think that that's a big gap right now for us in the veterinary world is that we need more of us around and out there and interacting with veterinarians on a regular basis.
All right. So one thing that is mentioned on the paper, it's like there's still no unified standard for how we classify resistance across sectors. So maybe can you talk a little bit about where we currently stand with AST standardization, and maybe what steps are needed, like to harmonize testing and interpretation between human and veterinary labs?
Yeah, I think it's a disaster right now still. Um, I think, you know, so I think we hinted at it a little bit earlier, but one of our biggest problems, right, is that we're asking our breakpoints and our data to do multiple things, right? We want it to be this clinical tool that guides treatment of one individual animal. And then we also want our data to speak about a population and about implications for human health and for environmental health and all these things. And sometimes I just think we're asking our data to do just a little bit too much for us. I certainly think our isolates can do that, but what are the actual drugs and mechanisms of resistance that we're actually interested in that have actual One Health impacts is really the question. As I'm sitting here, I'm like, oh, we need actually just a CLSI document where we agree upon what are the breakpoints that we're going to use that speak to actually what is a population level or One Health level question, right? That might be different than an individual animal where we're making treatment decisions based on that. So I think that would be like maybe an example step of something we could do or agreed upon. I mean, right now we can't even, and this is true in human medicine, this is true in veterinary medicine, this is true everywhere. We don't agree on what the term multi-drug resistance means, right? Like nobody actually agrees on that and what that means. And so, uh, I think it's, we can get into the semantics of everything. Um, I would just love to see a definition. I'll follow it. I don't really care what the definition is, but a lot of people do. And so, but I think the problem is that, the language that we have surrounding these things is actually not super standardized. What is standardized is what actually an MIC is, right? And so I actually think that the common language can be in the data. I just have to think about how we talk about that data. Sorry, just to say one more thing about that is that, so we have a PK breakpoint for E. coli's that outside the urinary tract from dogs and cats, there's no such thing as a susceptible E. coli for ampicillin. And that's because our breakpoint is set below the wild type distribution. And so if you follow that breakpoint, 100% of our E. coli's are to ampicillin. Very few of those organisms have a beta lactamase, right? Or at least it's certainly not an extended spectrum beta lactamase or other serious beta lactamase of concern. And so I think it's just important to like not layer our data that's interpreted with these standards and human data with is interpreted in these standards and say an R means the same thing as R now.
And maybe just, to kind of, you know, by now we have touched on breakpoints and to kind of just, before we move on to other questions, but, you have talked about it. So anything else when it comes to the implications for veterinary labs when breakpoints are missing or outdated?
Yeah, it ends up being a real challenge. A lot of times we have very limited breakpoints and limited information that can be useful for a veterinarian. And so when our devices are out of date, we really end up scrambling trying to figure out how do you overcome this gap. In some case, you can use e-tests and other like gradient diffusion tests on the side, but we're really stuck until we get an updated method. Part of it is actually hard to validate because we don't have reference panels. Some of you might have been familiar with the AR lab reference isolates you can order, or your company's awesome and they send you a whole panel to validate whatever you're doing. We don't have those. So even if it's an organism we would see in vet med, like Staph aureus, we wouldn't have drugs that are veterinary specific to go against. So there'd be gaps there. And then trying to explain those limitations to veterinarians, like Stephen mentioned, can be really hard, like saying, we can't actually give you much of anything, or that drug used to work, but now we can't say it works. It adds a lot of challenges to everything. And a lot of it is that communication breakdown. But we are currently working on major device updates, and I'm really hoping that helps us out. But it's also driving manufacturer interest and understanding the importance of these devices getting timely updates for our animal patients, because every animal result has a human tied to it, whether it's a cow, whether it's your dog that sleeps in your bed. It's all really important, and our diagnostics are important, even if it's just an animal. I'm saying that in quotation marks. Every animal result matters to me.
Totally. I think the other thing if most people are working on the human health side listening to this, I think another thing that's really important to sort of highlight is that none of veterinary microbiology is reimbursable, right? Like virtually none of our clients have insurance. I mean, some people have pet insurance, but it's pretty uncommon still too. So the cost of all these things is straight out of people's pockets, right? And that's something I actually take very, very seriously as a microbiologist, is that I know people are spending a couple $100 of their very hard-earned money to get a test result from my lab. And I think it's really important that my results are accurate and reflect that value. Uh, and sometimes it's really hard to do good microbiology inexpensively. And so when we're trying to balance cost and accuracy, in when we are a very small part of the market share, and so we don't have sort of the investments from manufacturers in the way that it is done on the human side, makes it really, really challenging, but it makes me take my job that much more seriously, I think, too.
Yeah, yeah. And one thing that you mentioned in your article was about with AST results and something like the idea of nudging and the influence of prescribing behavior. I just wanted to ask you a little bit more about that. So, like, how might diagnostic labs apply that concept to promote better antimicrobial stewardship?
So I think before the report, and one thing that we definitely have to do, and this is uh, critical, is actually educating our clients and veterinarians on what are appropriate and best samples to submit to microbiology labs. I think we really struggle with good sample collection, and then on the other side, rejecting those samples that aren't good too. And so something that we recently did is the American College of Veterinary Microbiologists sponsored an article that a bunch of veterinary microbiologists got together and kind of talked about what are best practices when vets are collaborating with their microbiology lab, that we published in the Journal of the American Veterinary Medical Association. And Kelly actually was the guest editor for that supplemental edition. And so it has had really great results. It's, I think, one of the top downloaded articles this year from the journal. So that was really exciting to see. So I think that the first and foremost is getting the communication out there before we have to put out the results, because results ultimately are the best way we have communicating with our clients, but only if we have good things coming in.
And to me, for our laboratory with the nudging concept, our laboratory reported everything possible to start with when I had first taken over the micro department. So everything on the test panel went out, and then it was up to the veterinarian to decide. And so for us, it was weeding through, and do we have a breakpoint for this species? And what can we communicate about the limitations? What are they routinely using? I think that's really improved our reports, and it opens a lot of conversations. So it's, why didn't you report clindamycin on my urine sample? So it's a conversation about it not being really a great drug for urine. So just some of those conversations, and it's really that communication piece, and that's something Stephen's article did a great job of emphasizing, is we're partners, and we need to talk as microbiologists to the veterinarians and to respect each other as professionals and understand that we're both trying to help from our own areas of expertise.
Yeah, just to jump off that, I think, there's probably a veterinarian somewhere in the Commonwealth of Pennsylvania every day that curses my name because I put out an Enterococcus result with only 2 drugs on it, but those are the 2 drugs that are gonna work for Enterococcus, and that's all you need, right? And so that's very different than sort of what a report from, say, a commercial veterinary diagnostic lab looks like, where there's a long, long list of drugs, but a long, long list of drugs that are clinically irrelevant and not gonna work. And so I think part of it is communicating that more doesn't mean better. It's about targeted results that are most likely and most efficacious to work. And so I think that's about building a trust with our clients.
And I think, in some way that kind of concept we apply it in the clinical micro lab. Even when we're working the cultures, right? We start releasing a little bit of information, and as we get more and we have a better understanding, maybe we put a little bit more out there. But that's always, we encourage, especially when people are trained, that they're like, okay, I want to help out and just tell them everything that I see. And like, wait, no, hold on, let's just
Well, and let's be right, moldy hasn't helped that now that we can ID everything, right? So, I think that's the thing too, is that, I was trained not with etymology. And so, I think now that we can ID everything, it makes it really tempting to report everything. And so, I think, what are actually appropriate terms and things that veterinarians will understand, like, right? Like growth of mixed fecal flora should communicate to them that likely contaminants. But you know what I can put on my report? Parentheses, likely contaminants, and then they'll leave it alone, right? And so sometimes I think it's important that we forget that sometimes we speak a language as microbiologists that isn't spoken by everybody else too, right? Or we put out we'll do verbal or text prelims sometimes early on. And so, we still use the term NHS and non-hemolytic strep in our lab as a way of talking about enterococci, but we still talk about NHS in my lab. We will tell like a clinician, I'll see a message go through that, oh, we have a non-hemolytic strep growing. And so they think it's a strep and it's actually an enterococcus, right? And so I think, not getting into our lingo too is really important. It's meeting them where they're at with their micro knowledge too.
Yeah, yeah. Well said. Yeah, we get involved sometimes in our own little micro world, and we kind of think that everyone understands what we're saying. And don't get me with Molly. Molly, that's a whole different conversation. That's a huge thing of mine. That before you look at a plate and someone has already spotted 7 or 8 things on the Molly, and you have all these names, and then you're like, oh my goodness. So here we go. So that's definitely something. Um, one thing that, right, so there's the need for more clinical outcome studies in veterinary medicine, right? So like everything, there are some barriers, right? So can you tell us, what barriers exist to conducting those? And of course, there's this huge value in collaborations, right? So there's the big power to it. So, and how my collaborations with teaching hospitals might help for that.
Yeah, so I think it has to happen across, particularly veterinary teaching hospitals, but also probably private industry as well too, if we're going to do true outcome studies. So I think part of it is actually getting all stakeholders involved there. Outcome studies are really hard to do no matter what, right? Because first you have to define outcomes, and like some diseases are really hard to define what they are in veterinary medicine as opposed to what the outcome is, because sometimes we don't get a full diagnosis every single time too, right? Because we are often limited to resources of the owners and things like that. So actually defining what the population is that we're going to do an outcome study on, I think is like a really big challenge there. And then what are the endpoints? I think is another really big challenge for outcomes studies. So what does a dog that's been cured of pyoderma look like? It's for blah, 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 blah. Or we also, for more serious diseases, we also have the outcome of euthanasia in veterinary medicine. And so that can complicate our analysis sometimes too, because that animal may have survived if they got on the right antibiotic, right? Or the right chip, but for some other value or reason, care wasn't continued. And that can make another, sort of iffy outcome that can be really hard to handle sometimes too. Um, so and then I think in other examples too, right? So like outcomes in companion animals look very different than outcomes in food animals, right? So it's time to return to being a milked for a dairy cow, or how many pounds of meat per feed efficiency for pigs and things like that, right? Too. And so I think ultimately one of our biggest challenges is defining what actual outcome studies are and look like in vet med. And then on top of that, paying for them. But we won't solve that problem today.
And part of that, just to step back for the clinical microbiologist, like what does this mean to you? So when we're developing breakpoints, the ideal situation is like a stool. So we have, or yeah, you know what I mean, like a stool. It has 3 legs. So you're going to have the
Stool, not
not
stool
stool,
sample.
yeah,
Yeah.
not the sample. So the one leg is the microbiology. So that's our MICs or like our zone diameters, whatever that data is. And then we're going to have clinical outcomes. And then we're also going to have the pharmacokinetics, pharmacodynamics. So we're actually going to be able to marry those things together to prove that what we're estimating from the bacteria and the PKPD will actually result in good clinical outcomes. And we just don't have that in vet med. It costs a lot of money. And like Steven said, there are a lot of challenges to defining what is good. So that adds a lot of extra challenges to our breakpoints and what that means for us in the laboratory too, and for interpretation and use by a veterinarian.
And one thing, like I guess for that second before you clarify what you were meaning, I'm like, when you said stool, my brain, I'm like, okay, I want to hear it. I want to hear this.
There's that I can remember being one of the first times my supervisor, like, we don't say stool in vet med, Maddock. It is feces or fecals. We don't talk about stools. The animals aren't sitting on the toilet.
And just to kind of add to the whole collaboration thing, right? And we know, like, overall, people are willing to help out and work together. And I think sometimes, things like this summits that we've been doing to, like, bring everyone in the same room, right? Here's what I have, my challenges, and then get those conversations going. So what else can you add to, collaborations between the human and vet labs? Whether what can they how can they do it better? Whether it's sharing data, reference materials, training opportunities.
I think all of the things. I know for CLSI, I'm really trying to come up with collaborations with the people in M100. And so when they're working on breakpoints that are something that we could use those same microbiological data, because of course, the bacteria, there are some differences, but ultimately, if we're able to contribute and you have diverse species and you're generating data, we can then use that for our different analyses. So I think that could be really helpful. Training, I think, and education are some of the biggest things, and just talking and interacting with each other instead of just assuming we're other, and figuring out ways that we can come together.
And one thing also is that was highlighted was the workforce shortages, and that we kind of touched on. And what do you think can be done to attract the next generation of specialists? What can we do to attract them?
It's a really great question. So I'm lucky enough to have a residency program here at the University of Pennsylvania. So I actually have two phenomenal residents right now. And so I hope I'm doing that already. How did I find them? I just had to go out and find really special and interested people. And, it was an active recruitment for both of them that we had to sort of do. And, I think, you know, uh, if we want veterinarians in these roles, which I think we do, I think certainly there's a ton of roles for people who have diverse backgrounds of training in vet med, but I think we certainly want veterinarians as well in these roles. And so, the debt to income ratio for veterinarians is obscene. And so we got to pay people better. um, so we got to figure out how to do that. And certainly I think, nobody became a microbiologists to get super rich, right? But, I think, making sure that the incentives that are there for things like public service loan forgiveness and things that help pay for those professional degrees is critically important. And, I think a lot of that is, and hopefully we get better at this as we move forward, is reframing all this as public health as well too, right? So that this is a service that's being done not just for the agricultural industry, but for everyone, right? The one health approach. And so I think ultimately, if we just show the value more of what we do and the impact that you can have, that will attract the right people to it, and then that'll attract the right funding, hopefully, as well too.
And from my perspective, it's keeping the options open as a medical laboratory scientist. If you are looking for another way to use your talents, maybe you love animals. I know that was a selling point for me when I was looking at career opportunities for MLS, was that you could work with veterinary samples. But just remembering there are other career avenues, and your talents are very valued in the laboratory for veterinary medicine also.
Yeah, yeah, and I don't know how maybe how aggressive they are with promoting it. Kelly, I don't know, because I think maybe you kind of, like, with me, my experience when I went through, yeah, and has some idea of, there's veterinary, labs, and we're doing testing, and maybe we saw a little bit of samples, but overall wasn't too familiar with it. Maybe now, as social media, it continues, and people are, from science, they're getting more aggressive on social media, and people are sharing things and letting know. And I know, like, MLS programs, they're going to high schools and colleges. Maybe they can incorporate that too a little bit, and let them know there's that option too, right? It's always that it's just not human medicine, but if they want that choice, it's there also. So let's say this is like a scenario where let's say that there's some funding, and they say, okay, wait, we have this amount of millions, let's say, for give it a figure, and they said, okay, well, I'm going to put you in charge of directing some funding for for AMR. So this question is for both of you. So what research or initiative will you prioritize first?
I think if I could do anything and just dream about it, right, is I would just pay for people's culture and susceptibility testing so they don't have to pay for it anymore as a veterinarian, or at least subsidize it, right? So when you go to the vets, you're not paying $300 for this. And it's an important resource. You just don't want culture everything, obviously. But for an appropriate case where you do need that to have that less cost. And there's some models out there in Europe that have done this where like you can't use certain drugs in companion animals unless you have a culture, but a culture isn't $300, right? It's subsidized. There's public, there's laboratories out there that are subsidized to help make these clinical decisions for animals in order to support that. And so that would be sort of my dream initiative. And the research, just my lab, just give me the millions and I'll figure it out. No, I'm kidding.
For me, it would just be investing in the diagnostic tools. I love Steven's idea because free cultures for all is probably the only way we're actually going to get the appropriate number of cultures we would potentially need. That would be the pie in the sky dream there. But having good diagnostics and good tools and just continued investment and recognition that it's important to have these good tools. And so maybe we would have rapid genotypic things that even my rural North Dakota vets could benefit from and get rapid results instead of 2 to 3 days after they've already been shipped in the mail to my little lab on the prairie. But, there's so many good things, and I think, yeah, we need to shoot for free culture and AST for all. That'll be it.
Like I like that. And that's something that it brings, and you mentioned earlier also, yeah, the cost, right? And maybe some people might not realize it. And I do hear, like I always, like in my experience, growing up, my mother was terrified of dogs. So we never walk every time she got really close to one, we had to go the other way. And so bottom line, no, I didn't grow up with pets. And then as an adult now, since I didn't grow up with them, I don't see, I guess that need or that bonding. I don't have that. So, but that's very true. When you talk about the cost, and some people sometimes, they have to take their animal to the vet, and there's a lot of money involved in it. So it just, yeah, thank you for mentioning that. It just,
Yeah, if you ask Americans in particular, if their pets are part of their family, they are, right? These are family members for people, and so they have deep value to them. And so, I think it's really about, if we can keep every member of our family healthy, that's our best situation.
That human animal bond is not to be underestimated. I think I even just heard an advertisement of supporting domestic abuse shelters that will allow pets so people can get out of those situations earlier. I mean, it is so important, and our pets are just so critically important to us. I mean, my Beasley is my little buddy, and she's everywhere I am. So I get it.
yeah. So, okay, there we have it. So free tests and diagnostics. Okay. So, and that's kind of like the episode starts coming to the end. I have like a couple more questions, driving towards like closing thoughts, and then I'll ask a really nice question that if you're I always like hearing the different answers that people have, and probably I don't know, Kelly's answer might be the same still, but we'll get there. So when it gives, what gives you hope that we're moving toward a more unified, sustainable approach to combating AMR?
For me, it's the people that I work with in the AMR field, in the microbiology field. It's the curiosity that I see in everybody. I'm never met with the idea of what I do isn't important or isn't interesting. They actually think it's like deeply cool what I do when I interact with people from other silos, which makes me feel cool, which is not something I feel that often. But I think ultimately, it is about the people and the drive, right? I think um you watch people make incredible strides, and change is slow and incremental. But if you like kind of look over, I just look at, I've been doing this for about 10 years now, and just the jumps and leaps we've made in 10 years, that's sort of what gives me hope. And it's not, the technology's there. Yeah. AI is here to help out, whatever. It's ultimately the people that I work with and do this work with on a day-to-day basis because we care, right? I think most microbiologists really care about what we do. And so uh I'll just say the people.
I'm gonna have to piggyback on that and say it's the group of people. It's what keeps me invigorated and passionate and hopeful. My techs and I in our lab, we're riling each other up on the daily, and that passion just drives us. And there's so much joy in what we do, and also that deep concern, like Stephen mentioned. I mean, it's just so much care there, and I think that it'll continue to improve and just, I mean, get our profession and importance out there, and just there's a lot of drive, and it's a great time to be in the field.
Yeah, no, definitely, and yeah, leaps and bounds, as you mentioned, Steven, so true, and it feels about the same thing, maybe a little over 10 years too, and so many changes from still pre-moldy tough days, um, and still very excited when that came through, and it's like the idea of wrapping your head about what we can know the answer, in the same day, and have that, so many changes, so yeah, and the people. So true, and beyond the lab, right? Like we go to these conferences, and then now it's full of a room of people that were going there to the same purpose, to learn, to meet people, and I don't know. It's like it's always. I love it. It's like all this, we're all going there with all this nerdiness. I just love it in one room. So it's great.
It's all about the nerds, right? That's the best part, right? Like nerds will save the world. It's gonna be us nerds. So, I'm convinced that's how it's all gonna work out.
Okay, so any when it comes to before the my favorite question. So any final thoughts on One Health collaboration truly means in the fight against AMR?
I think ultimately it's about not letting our egos get in the way, right? I think ultimately One Health collaboration really requires everyone to set down their pre-established notions that they have about other industries or other fields, and be open and lead with curiosity, right? Like, I think that that ultimately is what One Health collaboration is. It's really hard to be an expert in One Health, right? There's too much to know about a single problem to be an expert in One Health. I think there's some people out there who get pretty close, but I'm not that close, right? I don't know enough about all these other sectors to really be a good One Health practitioner. However, the reason I like trying to be a One Health practitioner is because you can kind of enter into these spaces with clear eyes, and open heart into learning, right? And ultimately I think it's about learning from each other and collaborating to try and solve these problems that are seem insurmountable. But ultimately, there is so much value in the collaboration, whether it helps one individual animal or it helps the entire world.
Yeah, completely agree with Steven there, and just piggybacking off of that, it is overwhelming, and there's so much that we can do that I really like to think of, what is the next right thing? What is the next small thing I can do? And maybe it's a phone call to a veterinarian to talk about topicals and how our susceptibility reports don't predict that necessarily, or just calling and talking through how to collect a good sample. That makes a difference, and hopefully it snowballs and gets people asking questions and thinking a little bit more, even what's going on in the clinic. But every little step we do to educate and discuss and collaborate makes a difference. So it's just taking those little steps every day and continuing forward in that fight, and to make sure that we are actually collaborating in a true One Health framework.
Yeah, definitely. Collaboration, education, learning, as you mentioned. Sometimes we come in and we don't we're unaware of what different sectors are doing, and that's always such an important part of my journey in this podcast here about stepping beyond the lab and see what people do, right? So, there's someone doing veterinary microbiology out there. This is from the industry. What do you know about them? Well, I know they fix the instruments, but what else are they doing? So it's going into that space and learning, and yeah, so true. Okay. So with this question, I'm gonna start with Steven. But this is a question that I like to ask, hearing different responses, and we tend to have that favorite bug, or as one guest one thing, one time said, the least favorite one. I don't have a favorite one, but I have one that I truly don't like. um, it can be for any reason, right? Whether that has a value for maybe you work with it in school, or some sort of research on it, some mechanism, maybe something as simple as a visual thing, or many reasons. But we all tend to have that favorite bug or least favorite. So, Stephen, what is your favorite bug?
So I think if any of my colleagues were listening, they'd probably guess I would say carbapenem persistent enterobacterales, but it's probably, you're right, my least favorite, even though I deal with it on a regular basis. And then you just mentioned the first bug that you worked with, and I'll always have a soft spot in my heart for strep parauberus. Streptococcus parauberus is the first bug I really did some work on. But I will have to say, my absolute favorite one is because of the teaching that I do actually here at Penn Vet. So I teach our veterinarians about microbiology. And my favorite slide to get to every year is the one that teaches them about Erysipelathrix rhizopapiae. And that's because I get to put up that giant word and watch their faces panic. And I find that really funny to do. um, but then I teach them that we call that disease diamond skin disease in pigs. And it speaks to how we can speak these common languages, right? About what pathogens do, right? It causes these blood clots in the skin and it forms these diamonds on the backs of pigs. Um, but for me, that bug always sort of reminds me, and I saw it for my first time ever a couple years ago at actually a dog sample, and I was like, "Oh," right? I was, like, so excited. It was like, a bucket list bug to get, and yeah, I just think that that bug speaks to how complicated micro can be, but also even just in writing out a name, but also just how simple it all can be sometimes too, right? Like that there's a beauty in that this bug sometimes causes this disease, and it's not that hard. Yeah.
I'm sticking with my basic Passerella multacida because I mean, it is the killer of many. It is all the things. Any of those species, and it's just always fun. I'm never bored of seeing a Passerella on a culture.
I'll probably regret saying it. I love the smell of pastrella too.
Little mousy owner.
Yeah, it, like, hits that same part of my brain that like, when you smell a new, permanent marker, like, it, like, hits that, like, olfactory center or whatever, so, yeah, I like that one.
Definitely some great answers, and yeah, I was actually doing a podcast that hasn't aired yet, but we talk about pastorella, and the person that I was talking to was sharing my story about orogenies, and how the first time that I saw one, and Gordon McConkie, and how fascinating, and then doing the research and finding out, that the patient was had a pig bite, which is something that you don't see a lot in Orlando, Florida. So that was very fascinating. So these are some great answers. So I know that we kind of did closing final thoughts, but is there anything else that you would like to add to the audience, or?
No, this was such a lovely, time, thank you, I really had fun nerding out for an hour.
It's definitely for the audience, it is great nerding out. So yeah. So for the listeners, as I said, if you check the show notes, you will see the link to the article so you can read it. And as always, once again, Kelly, always thank you for taking the time being in the podcast. And on a side note, Kelly always has some great ideas that she sometimes shoots me via email, and I love them. So please keep them coming. Great suggestions. And Steven, great having this chance to talking with you. And in the future, both of you, any topics that you want to share with the audience, you can come to Let's Talk Micro and talk to us. So
Love that, thank you so much.
Thanks for having us.
my pleasure. Well, there you have it. I hope you enjoyed this episode. As always, I enjoy sharing this information with you. And as usual, I invite you to subscribe to the podcast. You can find us on any podcast platform. If you go to Apple, Spotify, Amazon Music, Good Pods, we are right there. So please subscribe, download episodes. And if the app allows you to do so, please go ahead and leave a review. And you can find us on socials. If you go to TikTok, Instagram, YouTube, Blue Sky Social, we are there as Let's Talk Micro. On X, we are there as Let's Talk Micro 1. On LinkedIn as Luis Plaza. And there's an email address, which is letstalkmicro@outlook.com. And of course, there's the website, letstalkmicro.com. So either via social media, via email, via the website, you can reach out with any suggestions, any feedback. On the website, you can find study resources, licensing information, episode updates, and more. So I invite you to check those out. And if you want to support us in any way, you can do so via Venmo or via Buy Me a Coffee, KOFI. And both links are available on the show notes. And if you're looking to learn more about antibiotics, please check out www.learnantibiotics.com and the Learn Antibiotics book available on Amazon. These resources include cheat sheets, practice tests, games, and more. And they are being used by thousands of people worldwide and may be helpful for you or your colleagues. As always, these are some great resources from Dr. Timothy Gauthier, a very passionate pharmacist. And as you know, the Let's Talk Micro podcast is supported by the American Society for Microbiology. To learn more about microbes, visit asm.org. And that, my dear friends, is the end of this episode. I hope you enjoy learning about this information. You're learning more about veterinary microbiology, AMR, and One Health. Such an important topic. So stay tuned. Great episodes coming your way. I mentioned that I went to the AMR Summit in Detroit, and I am doing an episode about it. So stay tuned. But of course, I'm always grateful for your support. Thank you for downloading episodes. And please continue bringing that passion to what you do. It's so important. You do such great work. So, as always, stay motivated, stay safe, and of course, continue talking micro. Until the next time, bye.